Good afternoon. This is Dr. Havens with the recorded lecture for our Unit 4, Week 4 material. We are going to be focusing on chapters 10, 11, and 12 this week. Our first chapter is chapter 10, which addresses organizations, people, and change. Our objectives for chapter 10 will be to describe and understand the process of change, recognize the concepts of resistance to change, and identify its sources. We are going to propose some strategies for reducing resistance to change and also explore how do we assume a leadership role in implementing changes that are constantly coming in the healthcare workplace. A wise person once said, maybe it was Confucius, maybe it was the Buddha, I don't remember, said the only thing that's permanent in life is change. And the theme of a recent nursing management conference was change, change, and more change. Things are continually changing in healthcare due to new research, new technology, new proven ways of doing things that are better for, maybe better economically, maybe better for patient care. We don't know, but things are constantly changing. It can be called innovation, or it can just feel turbulent, but change is pretty much constant in the workplace today, and especially in healthcare. Another given is that mismanaging change is very common because we're humans. Humans are creatures of habit, and we sometimes don't handle change very well. In fact, as many as 3 out of 4 major change efforts will fail, either because of resistant staff or because of a resistant organizational culture. So I apologize for the clicks. My mouse has been working pretty well the past few days, but it looks like we may have a little bit of mouse trouble this afternoon. I am so sorry. But anyhow, changing the culture of any organization is really difficult. So when new policies and procedures come about that change the culture or the way that we've always done things, this is going to create some turbulence. And in this chapter, we're going to look at how people tend to respond to change, how you can be a change agent or a good leader of change in your organization, and how you can help people cope with change during times when it's difficult. Let us first take a look at 2 different types of changes that occur in healthcare, macro and micro changes, as described on page 150 in our textbook. Some examples of macro or large-scale change examples would be the onset of Medicaid and Medicare, which came about in 1965. This was the first nearly universal health care coverage in the United States, and for the first time, this meant that a lot of individuals had access to hospital coverage. Prior to 1965, a lot of the hospital care was supported by the community through taxes, and patients sometimes had to pay out of pocket if they didn't have private insurance in order to go into the hospital. If they could not afford to pay out of pocket, then they would be cared for at home by their families, and if the care was not sufficient, then they died. So Medicare and Medicaid was just a huge change in the U.S. Medicare provided healthcare insurance for everyone 65 and older, and also the disabled, and Medicaid in all 50 states became the coverage for people who are low income and otherwise uninsured. There are a lot of changes in the hospital system. There are a lot of acquisitions and mergers going on for financial reasons, and in some communities, the community hospitals are actually shutting down because they can't afford to operate the hospital anymore. And patients are required to travel further for hospital services, either to large regional tertiary care or teaching hospitals. Advances in technology are also macro changes, especially the robotic or minimally invasive surgical equipment such as the Da Vinci surgical robot. With these techniques, the surgery is much quicker, easier on the patient, more precise, and if you're not getting a large surgical incision, like with an open surgical procedure, then you can heal up faster and go home sooner. So this has been a huge macro change that has revolutionized many types of surgical procedures. On the macro or small scale level of changes, changes in nursing personnel can be tough, but they're usually small scale. Maybe a nurse who's been working there 20 years has decided to retire and she's got some big shoes to fill. So this requires an adjustment on the people who are left, adjusting to the new person, and the new person adjusting to the nursing unit. Sometimes nursing units and teams organize or reform. Sometimes a new nursing unit is started. When I was teaching down in Ocala, the larger hospital in the Ocala area, Advent Hospital, decided to add a new pediatric unit because it was needed in the Ocala area. There was no peds unit in Ocala at the time. Parents who needed their child hospitalized usually ended up taking the child either to Orlando or to Gainesville for hospitalization. This was very stressful on families, so Advent Hospital decided to take on having pediatric care there locally. So new graduate nurses may often find themselves, when they get to their first job, being given responsibility to help bring about changes in the healthcare workplace. Here are some examples of changes in which you might be asked to participate. It might have to do with, excuse me, introducing a new technical procedure. What this would look like might be how to operate the brand new brand of IV pumps that the hospital has just purchased, maybe a change in the procedure for Foley catheter care to reduce UTIs. It may be a new procedure for prevention of C. diff infections throughout the facility, and so on and so forth. They may be HR related changes having to do with how nurses are evaluated, or the ladder for promotions within the nursing department. May have to do with participating in QI or patient safety initiatives, and it may also be preparing for surveys and accreditation visits such as the Joint Commission, TJC, or other accreditors that have oversight over the facility in which you practice. Let's look for just a couple of minutes at Lewin's change theory. Kurt Lewin was a social psychologist who wrote this very famous theory about how people change. If you look at your own habits and behavior, you may see this in yourself, and it can be very insightful. He talked about three aspects of change: unfreezing, changing, and refreezing. So in unfreezing, this involves actions that create readiness to change. This is getting out of your comfort zone and getting used to new policies and procedures, new ideas, thinking about different ways of doing things. The change part of the theory is called the implementation phase. This is when you actually start putting these actions into effect, when you actually start practicing the new procedure or that kind of thing. Then refreezing is described as the restabilizing phase, during which the change was made, and now it becomes a regular part of everyday function. So now it becomes like second nature to do the old thing, and you move back into your comfort zone. This slide is just the diagram from our book that shows what these look like. Unfreezing is coming out of your comfort zone. Change is when you are in the discomfort zone, and then refreezing brings you back into a new comfort zone. In the unfreezing change or stages, we says this is when we're preparing for change. So this is when you're going to end services, you're reading emails, and you're reading the new policy and procedure. The important part of unfreezing is understanding the necessity for change and moving out of our comfort zone. So this is when we start thinking, oh boy, I've been using these IVAC pumps for so long, and now I'm going to have to get used to a new brand of IVAC or intravenous pump. They came for the in-service. The buttons are different. You have questions that didn't get answered, and you feel a little bit of stress about that. But maybe you really do understand the new options that are available with the new pump that the hospital has decided to buy, so you see the benefit of it for your patients. So there has to be a deadline that comes with some type of reward or punishment. If the deadline is November the 1st to start using the new pumps, and then you're caught wheeling an old IVAC pump out of the closet and using it, then there might be some kind of consequence to you. So you don't want to have that happen. There has to be a deadline, because if there's no deadline, we may understand the need to change, but we are not going to have the urge to change, because part of unfreezing is moving out of our comfort zone, and we want to lapse back. This is human nature, and stay in that comfort zone. Therefore, change doesn't happen. This brings us to the second stage of Cont'd-Lewin's change theory. In the change part of it, Lewin points out that this is kind of a journey and not a destination. It doesn't happen all at once. It's a process. Every time that you do the new procedure or use the new piece of equipment, it's going to be a little easier. So you're not always going to be stuck in the discomfort that you're currently feeling about the new policy, new procedure, or new type of equipment. So it's in this stage that we actually make the changes that are needed to better help our patients, please our employers, and so on and so forth, improve our skills. So people have now become unfrozen, and we're moving toward a new way of working. This is the hardest of the three stages, because it makes people feel unsure about their knowledge or skills. You may even feel anxious or fearful, but that's okay. Every storm comes to an end, and the sun comes back out and starts shining again. So you'll get through this. It's not an easy not an easy time while people are trying to learn about the change, and people need time to understand and adjust. And good management the people will realize this about their employees. So support is really important during the change phase. You need to get training, maybe have a webinar that you can click on and listen to multiple times. You may not get it all on the first time. People may need coaching, and it's understanding that mistakes will be part of the process. No human being is expected to get this right on the first time. People do well at things that they have practiced. So now let's move on past the change stage into the refreezing, or stage 3 of Lewin's change theory. So as the name suggests, this is when we establish stability once the changes have been made. So this is when you come to work for your shift and you realize, hey, it's been a week or 10 days since I started using that new brand of IV pump, and it's going pretty well. I can actually figure it out and make it work pretty much the first time now. So I'm getting used to it, and I'm calming down a little bit. At this point, the changes are accepted and becoming the new norm, and you may even hear a few people say, hey, I really like some of the options on this new pump. This is going to be great now that I'm used to it. So during this phase, nurses will become more comfortable with the new routine. Please remember, this will take time. It's not going to happen all on the first try. However, change is ongoing, so we're going to need to prepare to work through this cycle again and again, sometimes in the potentially very near future. Why do people resist change? This varies from person to person and situation to situation, but in general, people don't like going through the discomfort associated with having to change. So how can you increase your staff's receptivity to the changes? The first thing is just give them time to get used to it and think it over and become accustomed to how things are going to be different. How do we lower resistance to change? Well, you have to give people detailed information. This is not going to be a 10 or 15-minute huddle meeting that you get together and you say it once and then it's done. This is going to be probably repeated meetings, maybe emails, recorded webinars, training. Maybe the representative from the company of the new equipment needs to come and give a live presentation with Q&A, that kind of stuff. And then people need to understand the positive effect or the change or how this is going to impact the nursing unit. That makes it more worthwhile if they understand the value of going through the discomfort. At the heart of the matter, the bottom line is that the resistance or the problem that people have with the discomfort of change is managing their emotions around it, the anxiety or fear. Oh my gosh, what if I can't learn it? I'm never going to get it right. I was so comfortable doing it the old way, and that kind of thing. So one suggestion would be to tell a compelling story around why this change is needed in order to increase employee receptivity. This is often more effective than a carefully crafted, what we call an analysis of the need to change. Sometimes people don't need to see research findings and facts and figures. They need to hear a story that they can relate to, and also that will convey a sense of urgency to stimulate the interest in changing. How is this done? So we do this in persuasion or influence. So in order to help people adjust to change, you can appeal to their feelings. Instead of presenting statistics about the need to have a new policy and procedure for discharge planning and discharge instructions, you could tell the story of a patient who had a less than desirable outcome because of the current inadequate procedure around discharge planning and discharge teaching. So you could talk about a patient who collapsed at home after discharge from the hospital. He was being treated for diabetes. Maybe he didn't get adequate client education about managing his diabetes. Maybe he wasn't taught how to use the glucometer. Maybe he wasn't taught how to give sliding scale insulin. Maybe he was not taught about following a diabetic diet, and so on and so forth. So he collapsed, was trying to break his fall. Now he's fractured his wrists and needs surgery. So now with both of his wrists broken, he's in the hospital and he can't go home again. Even better yet, you could actually record a video of this gentleman telling his story with the repercussions of poor discharge planning, and this would be very effective. What nurse would not want to follow the new policy and procedure for discharge planning after they hear this gentleman's story? So also a show and tell type of demonstration can be very effective. For instance, showing a petri dish or culture plate of germs or pathogens that have been grown from swabs from ventilator equipment can speak volumes about the need for extra cleaning and infection control, especially now with COVID and things going on related to hospital-acquired infections. So if you give a display at the nursing staff meeting about the cost of disposable items such as chucks, diapers, so on and so forth, it's more memorable than if you just give a list of the price of these items, basically. Some important things to remember about change are that some people readily embrace change and love it, and many people do not. I think most of us are creatures of habit. However, there are people, probably the more adventurous souls among us, maybe this is some of you, I don't know, who get bored with routine, so they are excited about the possibility of a new procedure, something new and different, something novel to learn, something to keep their brain happy and active, a new piece of equipment to use, a new way to better take care of patients, and so on and so forth. But I think there is an element of many humans being creatures of habit, and change is stressful. Resistance to change is going to come from three major sources. Technical concerns, this goes back to we're no longer using the IVAC intravenous pumps, we're using the new brand. Personal needs around mostly time and instruction, feeling like you're going to be the last person to catch on, or so on and so forth. Anxiety and fear that you're just never going to learn it. And then threats to your personal position and power, which kind of goes in hand with personal needs. So when we're considering technical changes, we need to answer these three questions. Will it work better than the old way, and why? And have the staff been educated about this? Is the change really needed? And is there a simple way to do it? Simple is better than complex. Sometimes we will have advance notice of changes, and sometimes we will not. Just think in terms of how much, just over the past few months in 2020, COVID has changed our lives and the way we practice nursing. Nobody could have foreseen this even a month in advance. So this is kind of what it's like in healthcare. We almost never know what's coming. We should just be prepared as best we can and ground ourselves and hone our coping skills to deal with whatever life brings us next. Some of our difficulty coping has to do with things that are intangible, that don't necessarily affect our paycheck or anything, you know, our benefits, things of that nature. It has to do with our status, power, and influence. There's a scenario on this slide that I'll let you read on your own about a clerk in the surgical department of a hospital who had done the scheduling for many years, and then a new supervisor came in and that was changed. The supervisor hadn't realized the importance of this task for the clerk. So this gave the clerk a sense of importance and a feeling of status and power. So even though it was a very small change that took away the clerk's autonomy to do this, it threatened this person's sense of power and their status and their self-esteem related to their job. There is more than one form of resistance to change. It can be what we call either active or it can be passive. So active resistance is, this is easy to recognize. This is when the employee says, oh, I don't think buying those new IV pumps is a very good idea. Or if you change me to the night shift, I will quit. Or just refusing to do the task. There's no way I'm going to do that. So it can be an outright refusal to comply. It can be writing memos or sending emails going above the supervisor's head, or quoting rules that would make it difficult to implement the change, and also encouraging other people to resist the change. Some examples of passive resistance would be canceling webinars or meetings or failure to attend that have to do with implementing the change. Refusing to commit to changing, saying, oh, I just don't have time to learn that new IV pump. I'm going to go to the supply closet and continue to get out the old IVAC pumps, and then agreeing to it and saying, yeah, I'm on board, to the supervisor. I'm going to get it together. I'm going to learn how to use that new equipment, and then actually doing nothing. And this slide has some examples, some comparisons of the difference between active and passive resistance. Active is more like arguing, refusing, and attacking the idea. Passive is just more like ignoring the emails and the memos, not coming to the training, and then avoiding any discussion of the change. So what are some strategies to help people not be so resistant to change and help people accept the change that's coming on your unit or in your department? Number one, sharing as much information as possible. This is what's going to happen. This is what it's going to look like. This is what it's going to affect, and this is the time frame. This can help prevent misunderstanding among the staff. Helping to challenge beliefs about the change. Assert the evidence that current practices aren't safe or are not working. The new IV pumps are gonna be more effective. They're gonna save the hospital money, and so on and so forth. And also provide what we call psychological safety by expressing and recognizing people's concern, assuring people that adequate training and time to learn the new process or procedure will be provided, and that no one will be fired, and just assure people that you are going to be there to help them learn the new procedures. So what's the worst case scenario for implementing change if people adamantly refuse to follow it, or if there's an emergency situation? The nurse leader can dictate or demand change. This shouldn't be used very often. It can lead to a lack of motivation and disempowering the staff, which is a bad work environment, and you really don't want that. You don't want to give any orders or dictate to people how changes are going to be when there are opportunities for them to undermine you, because then you as the nurse leader will be seen as ineffective. If there are high motivational levels to make the change, then you're not going to need to make any demands or give orders. And it may be necessary to give an order when people refuse to obey, if there are not going to be any other negative consequences. Basically, in a nutshell, it's most appropriate to give orders or to dictate to people only in an emergency situation. It's much better to negotiate. There are 4 distinct phases of change. 1 is designing the change, 2 is planning the change, 3 is implementing, and 4 is integrating the change. These pretty well go along with Lewin's phases, except that there's 4 instead of 3. In the designing phase, you want to answer the following questions. What is it we're trying to accomplish? Are we going to decrease UTI rates by changing the policy and procedure for Foley catheter care? Are we trying to save the hospital money? So on and so forth. So is the change necessary? Is it technically correct? Will it work? And is there a better way to do things than what we're proposing? Then you're going to plan the change. When are you going to buy the new pumps? When are you going to hold the in-services? And so on and so forth. The third phase is implementing. This is bringing about the change. When are we actually going to roll out these new IV pumps? When are they going to actually be available on the units? And then 4th is integrating the change. This would be the new pumps are up and running and readily available for all staff in all patient rooms. Everyone has been trained. Most people have expressed a comfort level, and then we're okay to take those old IVAC pumps out of the supply closet and get rid of them. And this is just a chart from our textbook that shows the 4 phases. So in designing change, the nurse manager will take the lead, usually by trying to solve a problem. This has come about because maybe there's excessive hospital-acquired UTIs and you need to improve on the policy and procedure for Foley catheter care, as we've said. So they're trying to improve the system and improve patient care. However, actually making the change is going to require the whole team. So planning the change is going to involve getting people motivated, involving people in decisions that affect them and seeking their input, dealing with any conflict that comes up about this, trying to seek cooperation from people, providing coordination, and also fostering teamwork around here. Everybody put their heads together and figure out how we're going to get this done. In bringing about change on a nursing unit, it's important to consider the magnitude of the change. Is it major or minor? And also the complexity of the change. A minor change would be if you are trying to implement, like we said, a new brand of IV pump or a new type of thermometer. This can actually be fairly easily incorporated into everybody's work routine. However, a major or complex change might be redesigning the whole workflow of the unit. This is going to require a lot of planning, testing it out, evaluating what worked and didn't work, and then adapting the system before it's required in your department. And then the refreezing phase of change goes along with the integration phase of change. After you've made the change, this has to do with the need for the nurse manager to make sure that everybody has moved into their new comfort zone. So you want to ask, is the change well integrated into everybody's daily routine? Is it working well? Are nurses comfortable with it? And is it well accepted? Is there any residual or leftover resistance that we still need to deal with that could undermine it? So this might be you come to the nursing staff meeting a week or 2 after the new thermometers or the new IV pumps have been rolled out, and everyone says, oh my gosh, yes, we love the features on this new pump. They're so easy to use. I just don't know how we ever lived without them. Best case scenario. So what really might happen is, 1 or 2 nurses still a little grumpy about it, still having trouble integrating it into the routine, but hopefully a little TLC and maybe meeting with them and a little more hands-on instruction will bring them along. The integration of change is best measured by when nobody is grousing or fussing about the change anymore, when it has become the norm or a normal part of the routine. Then you know that you've hit success. So if you were the nurse manager or the leader of change, one thing it's important to realize is that you have to be willing to first change yourself before you can bring about change. Choosing to change can become a very important part of your development as a nurse leader. So the process of personal change is similar to the processes we've already talked about. such as you got to recognize, why the need for change, what aspect of patient care are we trying to improve, how are we trying to save money, so on and so forth. Then you've got to learn how to do things differently and then become comfortable with the new you and the new norm. We will always be learning new things, growing and changing, and trying to be the best that we can be. So personal change has a very similar path to the large scale change that's going on in the healthcare organizations for which we work. And this leads us to the conclusion of Chapter 10. Thanks for listening.